Hello, my name is Dr Anna Olsson Brown and I'm a medical oncologist up at Clatterbridge Cancer Centre in Liverpool. And I've been asked today to talk to you about navigating the side effects of treatments. And I'm going to focus on the side effects from immunotherapy treatments. So I always think it's worth just having a look back at the impact of immunotherapies on the treatment of melanoma before we actually think about the side effects, just to put that risk-benefit into context. So immunotherapies, or oncological immune checkpoint inhibitors as we otherwise call them, have been around for a good few years now. And they started out being quite sensationalist, these drugs that were going to really change the way that we treat melanoma and other cancers. And actually the science has been investigating whether that is indeed the case, and actually are these drugs the next best thing since sliced bread. And they certainly seem to have really changed the way that we treat melanoma and the potential response to those treatments for our patients. When we think about how they work, they activate a person's immune system to target and destroy their own cancer cells. So it's all internal. We activate the immune system, and that then goes forward and identifies cancer cells and breaks them down. And that's had a really big impact in melanoma. Prior to immunotherapy, and for some patients, the presence of targeted treatments such as BRAF treatments, actually the prognosis from diagnosis was actually very poor, and chemotherapy had a very limited benefit. And now we're looking at a very different situation where 1 year overall survival has increased significantly, and actually long-term enduring responses is something we see in about 50% of people are still alive after starting treatment 6.5 years down the line from their diagnosis of metastatic disease. So it's really, really changed the way that we treat these cancers and actually how patients are faring with treatment. Response to immunotherapy continues after the drug has to be stopped, either because we've got to the point where you've had 2 years of treatment and now we're increasingly pausing treatment to see if that treatment response can be continued without having to carry on receiving the drug. But also, if patients have had to stop because of toxicity, we see ongoing enduring responses. And actually, that's a very reassuring sign, and it means that we've essentially re-educated the immune system. And these are just what we call survival curves, but ultimately they just show us that, again, that's really changed, and the benefit and response to treatments for melanoma patients is very different. And that green line you can see, that top curve, is the use of combination immunotherapy in patients with metastatic melanoma. And that's a very different picture from the one that you can see on the left-hand side. So there's always a quid pro quo. And in this situation, the benefits that we see from immunotherapy have to be balanced by the potential for side effects. And actually, with this group of treatments, not only have we seen a different outcome in terms of the effectiveness of them, we've also seen a whole new group of side effects called immune-related adverse events. And essentially, they move away from established toxicities. So these are established toxicities of cancer treatments of chemotherapy, infection, nausea and vomiting, hair loss, anemia. These are the things that we associate with cancer treatments. However, immune-related adverse events are slightly different, and they come from the fact that we stimulate a person's immune system, their T cells, to be able to be active against their cancer cells. But sometimes those T cells get lost and start affecting other tissues within the same person, and that tends to cause inflammation in those tissues, and that leads to side effects. So essentially, because the immune system becomes uncontrolled to some degree, we then have to think about how we dampen down the immune system, usually using things like steroids or other drugs that suppress the immune system to try and manage and calm those toxicities down. So you may well end up, if you've had immunotherapy, receiving immunosuppression at some point to make sure that we're balancing the benefit and the side effects of treatment, because actually the toxicities rarely resolve on their own. The most common side effects we see are skin rashes, diarrhea, diarrhea and colitis, hepatitis, so inflammation of the liver, endocrinopathies, which is inflammation of the glands of the body, such as the thyroid gland, and pneumonitis, which is inflammation of the lungs. Now, there is a whole host of side effects that we can see, and anybody could get any of these side effects. Generally speaking, you wouldn't get all of these side effects, and certainly wouldn't get them all at once. It tends to be 1 or 2 areas of a person are affected rather than everything. And they tend to sort of happen one at a time in most people. So we do keep an eye out for any side effects that are affecting a person. So we do a very careful, systematic review of a patient before we give them each lot of treatment, and also we tend to do a blood test before each lot of treatment to make sure that all of the various organs are working and there isn't any problems from the treatment. In terms of how frequently do we see these side effects, when we talk about a grade 3-4 reaction, that's a reaction that requires somebody to be looked at and reviewed in hospital and may lead to a period of time in hospital. And that affects probably 1 in 4, 1 in 5 people on one immunotherapy drug. Goes up relatively high when you think about using 2 drugs together in combination. But actually what we found is some of these numbers are from quite old trials now, and increasingly as we are aware of the side effects and can recognise the early warning signs, this frequency is probably slightly lower in reality now. But certainly they are significant, they do happen, and we need to make sure that we're prepared for them when we're starting to think about using immunotherapy for the treatment of a cancer. This just reflects this. So this is a study that we conducted in the UK, and just shows you very much as we've said, sort of the types of side effects we see. So colitis affecting the bowel and giving diarrhea, thyroiditis affecting the thyroid gland, hepatitis affecting the liver, dermatitis affecting the skin, and pneumonitis affecting the lung are the most frequent types of toxicities we see. But we do see other things less frequently. So your doctors, when they're talking about the side effects, may well talk to you about just being aware of any changes that you experience. And also in terms of the severity, most people will get if they get a significant toxicity, it's still a toxicity that can be treated at home, and we use tablet steroids, particularly something called prednisolone, to manage those side effects. And it's most commonly that we can manage people and manage the side effects whilst they stay at home rather than coming into hospital. When do the side effects happen? Well, they can happen at any point, but we do see them most frequently sort of earlier on in treatment. But that's not to say they can't happen a long time after starting treatment. And also they do happen after you've stopped treatment. We have seen cases of immune-related adverse events happening a long time after treatment, sort of up to 2 or 3 years. So if the immune system is still active against the cancer, it would seem that you're still at risk of getting a side effect. Or and also if unfortunately it hasn't helped with managing the melanoma, the immune system can still get confused, and so people do still get side effects after stopping treatment either way. So we just need to be aware of those things and keep an eye on people, but also for patients to be aware and just monitor themselves for any changes they experience. I think that's really important because a lot of these toxicities present with vague symptoms. There are a couple, particularly colitis causing diarrhea and arthritis with joint pains, that are very symptomatic, and patients will be very aware of that. However, a lot of the side effects either give you very vague symptoms where you just don't feel right, or you just can't quite do what you were able to do 2 or 3 weeks ago. But there's nothing really to put your finger on. If you have those vague symptoms, actually that's the point that might mean that something's going awry, because they tend to have quite vague symptoms associated with them. So I'd certainly counsel my patients that if they have noticed change, it's worth just alerting their team to that, and just making sure that we don't need to check you out in terms of reviewing clinically or doing a blood test, because often a blood test is the only way we can see that toxicities happen, particularly with things like hepatitis. People feel completely well, but their liver function can be slightly impaired, and their liver can be inflamed. So often people come for a blood test before they have their treatment and are told that their liver's inflamed, and it feels quite unbelievable because actually they feel really well. But that does still need treatment. We need to make sure that we're treating any evidence of inflammation, because otherwise it will just continue to get worse, and that will mean we'll have to stop treatment permanently, and it will also mean we might get a less effect from the treatment than we'd like. So really, really important to treat those side effects, because actually we need to make sure that the rest of the person, their organs are all right. Otherwise that will obviously lead to problems outside of the cancer. The toxicities rarely resolve on their own, and we often have to use different immunosuppression, because basically the T cells are causing inflammation and there's no reason that will just go away on its own. So we often have to use drugs to settle that down. It's quite difficult to recognise. So it's those subtle signs I was talking about that actually are most common. So sometimes people present quite late with their toxicities because they haven't really realised that's what's going on, and we have to manage that when it happens. Some people are have toxicities that are really easy to treat and they take 2 or 3 weeks and they settle down and they're sorted. Others have a much longer journey, and unfortunately we can't really predict that at the moment. So reflare of toxicity and long periods of management and immunosuppression is something that a minority and a small minority of people do experience with these side effects. That can be quite frustrating and difficult. But it does unfortunately happen, and we need to be quite careful and monitor people to make sure we understand if things are getting better or not. Taking the drug away doesn't stop the toxicity from happening. It doesn't terminate the toxicity, so we still have to manage it even if we're not giving more immunotherapy. The fact that this is all related to the immune system does tell us why these side effects are happening, but we need more information to be able to manage people in an optimal manner. I'll talk a little bit more about that in a minute. We need to make sure patients have regular follow-up when they've got side effects, because they can wax and wane, they can get worse. And also the treatments can be confusing. So actually regular follow-up is one of the real key things, I think, of this. And forming that supportive relationship between your cancer team and the patient is really, really important, and helps people manage the side effects and the effects of those, the impact on their lives. So certainly myself and my team in Liverpool have put a lot of work in to make sure that there is a regular follow-up for patients. And partly at the moment we have a problem because we don't have any clear predisposing factors. We're getting a little bit closer to understanding it, but at the moment we can't really at the beginning of treatment predict who's going to get side effects. So that leads to quite a complex relationship between side effects and treatment benefit. So obviously the treatment benefits are potentially very, very high, but we have to balance that with the impact of side effects when they happen. So that, I think, certainly manifests itself initially as uncertainty. What's going to happen to my cancer? What's going to happen if I get side effects? What will happen as I go through treatment? So lots of uncertainty at the beginning. And I think immunotherapy has brought great benefit to some, but it's really changed our ability to predict what's going to happen right at the beginning of the cancer journey. And so it leads to that needing to wait and see what happens for a while, and that's really scary. And so we need to help support and navigate that. Short-term toxicity has its challenges. It can lead to hospitalisation and period of time spent in hospital. The side effects of steroids aren't insignificant, and they do impact quite a lot. And we can't deny that, but we do need to try and reduce that. Part of that's in the preparation about what to expect when you're on steroids, but also partly about how we best manage some of those side effects. The fear of side effects, the fear of what that means for the cancer, the fear of what that means in terms of treating the side effects, the fear of that meaning having to come into hospital, really significant elements to the treatment. And also people, when they're having treatment for their side effects, can get quite deconditioned. Steroids don't make you feel brilliant, it can interrupt your sleep. And so actually we need to be quite aware of the fact that that can happen to people, and try and give advice and support on how to prevent that happening. We have noticed and are aware of the fact that there are long-term toxicity issues for some, and I think that's become more apparent as the treatment are more effective. So people are living for longer. So we're starting to sort of slowly understand and navigate and get a better picture of what long-term toxicity might be. And obviously you're always still worried, and the impact and interplay between the long-term and how the melanoma is behaving, and how whether you're getting, whether there's been a response to the immunotherapy, or indeed toxicity can happen if there hasn't been a response from a melanoma perspective. So that there are lots of things and challenges that we need to navigate together to make sure that there's a support system there, and also that we're gaining the benefit that the immunotherapies are meant to yield for us. And then there are the side effects of the immunotherapy immunosuppressions that we use, and how that impacts on people in the longer term. And that can be simple things like having to have blood tests to monitor those immunosuppressants, and also the longer late effects of being on immunosuppressant treatment, which are relatively rare, but important to be aware of. So it's a complex journey, and that sort of working very much together to navigate that is really important. So I think there's always a concern when we talk about using immunosuppression for toxicity as to whether that will impact on efficacy and whether the treatment will still work. And certainly all the data that we have to date suggests that actually, quite amazingly, if you give immunotherapy and there's a response there, that actually giving steroids for an immune-related adverse event doesn't actually stop that from happening. And you can see here this survival curve with the green and the blue line. That's a group of patients with melanoma, and you can see actually those that get side effects actually do a little bit better and have better outcomes. So getting a side effect isn't necessarily a bad thing. It just means we need to be really careful and focus on treating those side effects well and making sure patients get better as soon as possible, and hopefully try and stop them getting severe side effects. And the way that we do that, as I said, is generally speaking with tablet steroids if we can, intravenous steroids if we need to, and then actually getting other people involved who are used to looking after those organs that are inflamed, so that the oncology teams are working with other professionals. And what we tend to find is that we have this, what we call a toxicity management cycle, where a patient will start and identify themselves that they've got symptoms and side effects. They'll come in and be seen by either one of the acute medical team in A&E or in the general hospital, or they'll come in and see their oncology team, and they will identify that there's been a side effect there. There'll be a review of that side effect and actually a decision about whether there needs to be treatment and whether we need to start immunosuppression. There's then a long period of monitoring whilst the immunosuppression is working and the side effects are being treated, where often patients are at home being treated as an outpatient, and then their teams are calling them or seeing them in clinic to make sure that those toxicities are getting better. We aim to resolve those toxicities, and in the vast majority of people, we can resolve those toxicities. And then actually we need to think about what we're doing in terms of the treatment of the melanoma. So we find that there's a sort of this cycle that is in place. One of the most important things is asking if you think you might have a side effect. So actually patient awareness, and certainly in my centre we have an immunotherapy alert card with a number to call if there's any concerns. It's really important that we're aware of the side effects early. The earlier we catch them, the earlier we can treat them, and the easier it is to treat them, because actually once we find that inflammation has become sort of fairly established, getting that to reduce down and to go away is much harder than it is if it's just at the beginning. So I really encourage my patients to ring us, even if they're not sure something's going wrong, to make sure that we can actually manage it effectively. And we often call on other people, so it shouldn't be a surprise to patients if we ask them to see a gastroenterologist or an endocrinologist or a rheumatologist. We have a great group and network of individuals that both nurses and doctors, who are gaining experience in managing these side effects, and we all work together to manage it depending on which part of a person's become inflamed. So it's not uncommon for patients to be seen by people that aren't their oncologists while we're managing their side effects. And the impact of immunotherapy and immune-related adverse events has been sort of fairly well documented, and I've certainly spoken to my patients extensively about what this means. And I think there are a few elements that are a surprise and a few things to be aware of. So people feel generally well whilst they're receiving treatment. It's not the same as chemotherapy. You don't feel really quite tired and washed out most of the time. Most people feel quite well and often can continue working if they were working before they started treatment. But they have this sort of episodic side effect, so they'll be fine, then there'll be a side effect that will be somewhat of a surprise, and normally you'll feel really well, and then a side effect will happen. Then there's a period of treatment of that side effect with drugs that suppress the immune system, and then either people will go back on treatment, and more people are going back on immunotherapy treatment after a side effect. Or actually then we enter a period of surveillance where we're wondering and monitoring how the melanoma is going whilst we're sort of managing the side effects. We don't know that quality of life compared to other cancer therapies is improved with immunotherapy. So there are certain studies that have compared chemotherapy and what we call TKIs, targeted therapies with immunotherapy, and people have better quality of life on immunotherapy generally. But there is episodes of significant morbidity. It's hard if you experience a significant toxicity. And actually, hospital stays do occur, particularly when we're using combination therapies in melanoma. And sometimes people have to be on prolonged courses of steroids. The steroid doses can be confusing. There's lots of little tablets and knowing how many to take. So actually that relationship with the oncology team that's helping support the person with the side effect is really key to make sure that the steroids are being weaned in the right way. And the reality of toxicity is very challenging. It's hard, actually it's a significant event. So it's just making sure that we help support patients while they're experiencing that. And actually there isn't at the moment there are lots of different cancer groups, cancer patients that are receiving immunotherapy, not just within melanoma, but within many other cancer types. But there are increasingly groups of support groups for patients who've been experiencing side effects from these treatments, because they are so very different from the things we've seen before. And as I said before, we can see late effects, and we are seeing late side effects. So it's about how we manage that. And certainly teams such as ours are setting up late effects clinics. So actually we can make sure the patients are supported for the long term, not just while they're in the early stages of their side effects or early stages of their immunotherapy. So I just wanted to briefly mention a patient who was given his permission for me to talk about his story. So he was one of the first patients I saw with immunotherapy toxicity. He was a 41-year-old gentleman who was diagnosed with metastatic melanoma in January 2018 and started on combination immunotherapy with 2 immunotherapy drugs. And after 2 cycles, he experienced what was described as eye pain and inflammation, and he came into the cancer centre for review. And this is how he presented. And actually what had happened was he'd got inflammation of the muscles around his eyes. So that was pushing his eyes forward and giving this appearance of inflammation. And his eyes were lots of soreness and quite a lot of headache as a result of this. And this was not particularly expected. It was something we hadn't seen before. And so we had to navigate this. And actually he ended up with quite a long treatment course. So from between March and July, I was treated with high dose steroids and actually a drug called methotrexate, which also helps suppress down the immune system. His symptoms completely resolved, but it took about 15 weeks for that to be the case, to actually get to the point where the treatment for the side effects had worked. And we did a scan at the end of that period of time to see how his melanoma was faring, and actually showed a complete response to immunotherapy. So in August, he was very keen to start back on immunotherapy. So we reduced down from combination to single agent treatment. And he had some very low level mild side effects following that, but actually was very manageable and didn't ever get a refer of the problem with his eyes. And then he went on to complete 2 years of treatment in January 2020. And I saw him just last week, and he's got an ongoing complete response with some mild long-term side effects. So he has a little bit of aching in his joints, and he does have a little bit of fatigue. So we're managing that under our late effects clinic, but actually he's living a normal life. He's working, he's bringing up his daughter, and had really good responses. So even though the side effects were quite startling and actually needed quite a lot of treatment, his melanoma continues to respond and has continued to respond for the long term. So I just wanted to mention briefly in my last slide about research. So we're really keen to understand more about this. I think oncologists are really keen to be able to manage this better, to support patients better. And so we're doing quite a lot of research and certainly we're forming sort of national collaborations to try and understand this better. And so we want to look at how we predict these side effects, research into what actually happens, what the mechanisms behind the side effects, how to optimise the treatment of side effects. Should we always use steroids? Should we use other drugs? There's a whole host of other immunosuppressive agents out there that we really want to understand whether we should use those instead. What late effects are we seeing, and do we need to understand more about those? And also much more about that wraparound support. How is it? What are the impacts in terms of quality of life, and how do we best support patients whilst they're experiencing side effects? Many thanks for your time.